Thanks, Louise. That's great. Um, so, obviously, I'm just seeing everyone's kind of joining in there now, and we're saying there's kind of a lot of people from all over the UK and across parts of the world as well are kind of joining in. So we'll give it a minute for those people to kind of catch up. But I'm based in northeast of England, so Newcastle, which you can see in the background. I've got there's the Tyne Bridge, and actually the bridges that go along the Tyne. Yeah, that's fine. But yeah, obviously, just want to try and keep it to about an hour or so tonight. I know it's a UK time, it's 8 o'clock in the evening, and it's quite a nice sunny evening, so people probably want to get the last bit of daylight before. But yeah, I'll just see if I can share my screen there now. So, endodontic diagnosis and decision making. It's really just a sort of overview again, going through, why we're doing endodontics in the first place. What are we looking for when we're seeing patients, especially now, when they're coming in either complaining of signs, symptoms, and what signs we're looking for, and how that can lead to our decision making and what we're going to then start to do for that patient, and especially in the emergency management of these problems as well, and which ones are strictly speaking the emergency need to deal with there and then, and which are the ones you can kind of plan to do, and how best to sort of do that as well. So yeah, learning objectives. Really, what are the key diagnoses in endodontics? What are the things that we're seeing day to day, and how do we get to those diagnoses? What's involved in doing that, and the further investigations we can do. That's including the sensitivity and specificity of these tests. So that's where if there is disease there, how well can our tests say yes, there's definitely disease there without getting any false positives? And again, if there's not disease there and if it's healthy, what tests are we doing to say that yes, there is? We can prove that there's no disease there, and this isn't necessarily what we want to do. Briefly, a tiny bit on the non-dental causes of oral facial pain, because we will see some people who are complaining of things like toothache, but with often confusing symptoms, and we need to know in some areas that when it might not be pulpitis or one of these sort of things, that we then have something else to kind of fall back on and think, well, why else would this person be getting this level of pain? And then a little bit about the emergency treatment provision. And again, in the UK at the moment, we're just sort of opening practices back up outside the urgent care centres, and so probably likely to see a bit of a backlog of these emergency appointments and treatments, and it's deciding which ones are going to, we need to prioritise, and how we want to kind of go ahead and what sort of level and stage of treatment that we need to kind of get through to do that. So the key endodontic diagnoses that we need to think about are pulpal diagnoses and the periapical diagnosis. So the pulp can be in sort of 4 states, as we say, which is healthy pulp, which is hopefully what we all have at the moment. We're going around, we're not aware of the teeth. The teeth, they're vital, they're responding to extremes of temperature, but then they're not, giving an exacerbated response to that. It's healthy, it's healing, it's doing what the pulp is designed to do. And then we've got the 2 pulpitis type diagnoses, where we've got reversible and what we deem irreversible pulpitis, or sometimes deemed symptomatic irreversible pulpitis. And these, in essence, are histological diagnoses, but we are trying to find out, by using our further tests and the questions that we're asking patients, what level the pulp might be in, because it could be that we don't necessarily need to do a pulp treatment, but we can deal with the sort of irritation that's causing that initial reversible irritation, or whether actually that pulp is progressing and we need to think about how we're going to remove that source of inflammation that's actually within the sort of pulp that's not going to settle by itself. And then we have pulp necrosis, so when a tooth is completely dead, for reasons that we'll come on to, and then how we're sort of running tests to see if that is definitely the case for the pulp diagnoses. And then we have our periapical diagnosis, which again, always the first one we have healthy pulp, healthy tissues, healthy apical tissues, healthy periodontal ligaments around the teeth, and healthy gingival health around the tooth. Or do we have apical periodontitis? And again, we use some terms interchangeably, whether it's symptomatic and acute. So is it painful? People sometimes use it as acute because it's, people are acutely aware of it, it's happening there and then, or is it something that's been there for potentially a long time when we say chronic, or is it asymptomatic? Are we seeing signs of apical periodontitis that they're not getting pain from? Sometimes that's when we'll deem it chronic or asymptomatic. And then chronic apical abscesses and acute apical abscesses. Again, you could sort of deem these asymptomatic and symptomatic. Your chronic apical abscesses are things that we'll see and there's sort of some future slides where we've got sinuses associated with teeth, these sort of long-standing infections that have been there, and there isn't technically an abscess, but it's chronic because it's not within a contained space, unlike something like an acute apical abscess where we have a big area of sort of facial swelling that's associated with it, and they're the sort of ones that we need to be more aware of treating quite urgently. So it's always good to go back and think with all these things, why a pulp, why are teeth alive in the first instance? Why can't all the teeth just be dead, and then we wouldn't have these issues with teeth becoming sensitive, or okay, people getting this level of discomfort, this pain. But it's the reason that teeth have pulps is because that's how they're formed, that's how they're developed. That we have two sets of teeth, and obviously as you're growing through your adolescence, that's when your teeth are developing, and you need that pulp and you need the odontoblasts within the pulp to lay down the enamel and dentine, etc., as we're going through that. But what it also provides is, once the teeth are fully formed, partly is the ability to sense things within the mouth, whether it's temperature or actual proprioception, eating and chewing, so we know how much force, etc., putting on teeth, etc., and how we can feel things, move things within our mouth, which is you're not so aware of. It's just as you're sort of moving food around, your body is listening to that pressure and knowing where things in the bolus is within your mouth. And then actually, as a defense, it's very important as well, because your teeth are probably one of the few things that actually go from hard tissue through soft tissue in your mouth and have like an area. And it's really important that it's not a pathway for bacteria, etc., to get into the body and into the sort of bloodstream, etc. And that's why we see things like reaction reparative dentine. That's the pulp's response to a stimulus such as a bacteria, and it's actually your body's trying to protect itself. That's what a lot of apical periodontitis is the body trying to wall itself off, so that these bacteria and the bacterial byproducts that are coming out of the apex of the tooth aren't getting anywhere. This once the tooth has died, and so part of that defense is its ability to create tertiary dentine, reaction dentine, reparative dentine, to try and maintain that vitality in the tooth, to keep that tooth alive, so we can then continue to function and have the benefits of this. So again, it's just going over basically what's involved in the diagnosis. When a patient comes in to our clinics, our practices, we're wanting to glean information from them that leads down a pathway, a surgical sieve, so that we can then provide treatment to manage whatever issue and what problem they're having. So as with any diagnosis we do, we need to make sure that we're getting a good history of how the patient has got to this point. Now, some of these things we've been a bit limited with just phone triage, but you can actually still take a lot of information from that patient, be that what they're currently complaining of, how they've had that sort of pain history over what period of time, what's been done to the tooth. Have they seen someone recently for restoration, or has it been like that for years? Have they had history of previous root fillings? Have they had a history of trauma or orthodontic treatment? So there's a lot of information that we can start to gather at this point that can lead us in a direction of the diagnosis that we're going for. And then we have the things that obviously we're quite usually trained to do, the examination. Are we checking extraorally? Are we seeing signs of any swellings anywhere? And are we seeing signs of any inflamed tissues, or outside the mouth, physical swellings, any asymmetries in the body? And then we move on to our intraoral exam, again, which is what we're probably all doing routinely, but it's sometimes we're thinking, do we have a structure and an order to how we're doing that? Are we looking just, at the hard tissues? How we're looking and assessing the soft tissues? How we do, we've got a BPE probe, we're checking the perio health, we're checking for cracks, fractures, etc. And then we're moving on to sort of our special investigations that we then think are then going to, continue us down that pathway of getting to the diagnosis that we want to get. Things like your vitality testing, sensibility testing, your percussion, your palpations, and then radiography. And again, the types of radiography that we now have available to us isn't just solely plain film and 2D imaging. We now obviously have cone beam and 3D imaging as well, which is becoming more and more used, and we're seeing it, the amount of additional information that we're getting from that is affecting our diagnosis from quite an early stage, and that may lead us to how we choose to treat and plan these cases a lot more effectively, all to the benefit of the patient, that we're not trying to put them through, longer appointments or appointments that may not be necessary. We can see and we can get more information from these tests that can kind of guide us about how we feel best can provide a solution to these issues we're seeing. But yeah, we'll go through some of the sort of symptoms that patients may, come and explain to you, and especially things you have here on the phone is how people are finding, what are they eating and drinking, and how that affect, that is having on their teeth. Is it hot things that are setting off? Is it cold things that are setting off? Is it extremes of temperature, or is it just something small, when they're eating just normal room temperature food? How is it when they're biting it, they're touching it? A lot of times patients say it's when they're actually brushing their teeth and they're sort of, loading the teeth in different directions. That can sometimes give us a bit of further information. Have they said, they come and say, oh, I've lost a restoration 4 or 5 weeks into lockdown, and now I've got to this point, and these teeth start to become loose, or they're mobile. Is that the whole tooth that's mobile, or are there, fractures and cracks that we're looking for as well? And then there's the clinical signs that we're then going to do and test for, but only after we've got that good history, because that's going to give us certainly a good indication of the sort of further tests that we're going to want to do and start to look at. And certainly clinical signs, vitality testing, is always really useful. I think if you're only sort of 2 minds, you've got to make sure that you're doing cold testing, hot testing, etc. We'll come on to that as well. A lot of people, used to sort of tapping on teeth at the back of mirrors and, percussing the teeth and percussing them in different ways. You don't necessarily have to smack it with a mirror to know. If someone comes in and tells you, oh, it's really, really sore, I can't touch, I can't bite on it, you don't then need to smack it with a mirror for you to then, get a positive percussion test. You can just gently load that with your finger, and that's going to give you good information. Palpations are really useful as well. We're checking this, buccal sulcus, lingual sulcus around these teeth, having a little, feel around the tissues there, feeling for any sort of fluctuation, or, where it's tender, etc. Caries, we all can see and diagnose caries, and again, we're going to come on to sort of radiographic signs of caries as well. Does the tooth have a restoration? Has it got big overhangs? Has it been, restoration that's been done very recently, and it's a very deep restoration? And also, peri-health. Perio is one of the big things you also want to be checking these cases as well, because we want to make sure that, as well as diagnosing that as a potential cause of the, pulpitis, etc., or necrosis, we want to make sure that, is this tooth still suitable and, viable for treatment, or has the perio got to the point where actually that's going to not just impact our diagnosis, but impact what treatment options we're then going to kind of discuss with the patient as well. And then the radiographic findings, obviously people looking for widening of laminar space now in something that's, necrotic and it's got, asymptomatic apical periodontitis that might have been there long-standing. You can see bigger lesions on these teeth. But if it's something that's irreversibly inflamed, you're not necessarily going to see something. And also the sort of quality of the radiographs that you're getting, are you using sensors, using phosphoplates, you're not always going to see the widening of laminar space, and especially not on a single image. So sometimes you may want to take a second image from a slightly different angle. You're going to see and get a bit more information there. And certainly if you don't see something obvious from your sort of clinical signs matching up with symptoms that you're getting, taking a second view is often really, really useful. And that's going to again show us signs that, are we seeing caries present? Are we seeing failing restorations? Are we seeing huge amounts of bone loss around the tooth and where that bone loss is? Are we seeing evidence of cracks? I'm not saying that we're seeing cracks, because again, you're not going to see that unless it's a huge crack, but are we seeing evidence of cracks and these J-shaped lesions that we might start to see around teeth that might have root fractures, etc. in them? And history of trauma you could see on anterior teeth. If the teeth have had heavy trauma, you can sometimes see horizontal fractures that way. But yeah, we'll kind of go through and touch, whenever we're seeing a tooth that we're considering doing a root treatment for, or the patient's complaining of pain, we've always got to think, well, is it a pulpal inflammation or pulpal necrosis? Why is this tooth, got that level of pulpal inflammation? And it's, largely always to do with bacteria. All the sort of seminal endodontic studies back in the 60s were looking at sort of rat specimens and exposing pulp tissue, and then putting it in a bacteria-free zone and a bacterial filled zone. You're going to see where the inflammatory response comes from. So we know it's all to do with bacteria. So we think, well, how are bacteria possibly getting into these pulp spaces to cause the symptoms that the patient's getting? So if you see a completely unrestored tooth, then you start thinking, well, why would they be getting this level of symptoms? And that's when you start thinking potentially things like cracks. Whereas if you see a tooth that's super heavily filled, got secondary caries all around it, it's got peri around it, well, there's a number of areas where bacteria might be getting into then. Again, a lot of this stuff is just the principle. There's a great book is The Principles of Endodontics by Tell and Barnes. I know Paul's very keen on, actually doing your background reading, your literature, and actually getting some of these sort of seminal books that actually kind of break a lot of this stuff down. but yeah, you need to sort of be considering, why would this tooth be giving symptoms, and what am I potentially looking for? That's very easy. Say you've got big restoration and lots of caries around the tooth, but if it looks like, I've seen a couple just this last week, unrestored lower molars, that have been referred through to patients of complaining of pulpitis type symptoms, leading on to sort of like really acutely apical periodontitis, and I'm sort of triaging them over the phone initially and thinking, oh, I've got a radiograph from the referring dentist. I think, well, cracks are really quite likely in some of these cases when it's completely unrestored, but all the other symptoms point to, pulpitis that's leading to, acute apical periodontitis. We've got to be really thinking, are we going to be seeing cracks in these teeth, and where does it go? And the couple I've seen this week have had, pretty severe cracks running centimetres distal through the teeth. And obviously, treatment of cracks and root filled teeth, knowing how bad a crack is a different sort of lecture altogether. And there's a lot you can kind of go with that, and when these things are suitable for treatment, when they're not. But certainly, cracks in teeth is something we're seeing a lot of, especially if people are heavily stressed or bruxing, got occlusal issues, which during something like this and with COVID-19, a lot of people are probably more stressed than ever. They're working from home, got a lot of extra responsibilities. They can be clenching a lot in these teeth, and that's another one of your extra oral tests you can look at as well. If someone's got huge masseters and they've got signs of wear facets all over their other teeth, and you're looking at teeth that are potentially heavily restored, you want to be thinking, is there a crack in this tooth? Is this why potentially it's gone? Because that's really going to impact your management, but also a lot of the consent process that you go through and how you then discuss that with the patient, and the sort of not guarantees, but the prognosis that you can give someone. And if someone's got a crack in a tooth and I can see it and take a picture through a microscope, and he needs to be using magnification really to see these things, it really is going to impact on how you're going to discuss the sort of ongoing treatment. Whereas if you can see it's just a large carious lesion that's gone into the pulp tissue, then it's often a little bit more obvious about how you're going to treat that and how you're going to manage that as well, and not just in an emergency appointment, but also going forward as well. And so yeah, so how do the bacteria get in there? Is it directly? Is it things like trauma, cracks, or caries, or is it indirectly? So when we've got periendo lesions, you've got a lot of recession around teeth, and those dentinal tubules and the root surfaces are getting exposed, and sometimes that's another way bacteria will gradually get into these teeth over time and start to cause these areas. And they're often the ones where you see teeth don't necessarily get irreversible pulpitis and die off in a flurry of pain. They're the ones that often kind of just meander out of light, become necrotic over years, and then these are sometimes the ones you pick up on radiographs at a later stage where they've got this chronic asymptomatic lesion, because it's just a tooth that's gradually had the bacteria have got to a level that they've overcome and won. And again, this is a little bit mentioned when at the start where saying, why are teeth still alive? And it's because if you've got a mild stimulus over a short period of time and the bacteria there and it's gradually getting through, well, the pulp can recede and can help itself and protect itself by laying down more tissue, versus strong stimulus where it's happening too quickly, you can't lay down tissue fast enough to do that. And that's often sometimes why it'll sort of die. But so it's a really good book, that one from Patel and Barnes. So yeah, we'll go through some of those kind of pulpal diagnoses first. And just got to break these down and give you some clinical cases where you're likely to see these, and an initial management of what you'd like to be doing, because a lot of the cases now people will be seeing in practice will be reversible pulpitis, because people have had planned restorations that haven't managed to get in for, or they've just had slowly progressing caries. These are some of the things, or chip broken fillings. These are sort of things you're going to be seeing quite routinely, and it's known when that's gets you to the point where you want to do emergency treatment, or whether you're planning to do your definitive treatment. So stuff like this we'll see all the time. We've got leaking restorations, we've got caries in teeth. These are ones that people will often come in with vague symptoms of temperature sensitivity. Could be hot, could be cold. Cold's often worse for reversible pulpitis, but it's quite often in short duration. It's it's a sharp pain they're aware of. Take away the stimulus and it goes away. Certainly temperature is one of that, but also sweet things. You've got missing restorations and things can get in that area and just cause a little bit of fluid movement within those tubules. That's where patients are starting to kind of feel this, and it's just an indication that we should be looking for that cause of the initial irritation. Radiographically, you might not see anything. You might see caries on a radiograph, but you're not necessarily going to see anything periapically. But this is what we see all the time. The treatment is, you remove that cause, you remove that stimulus. It's whether or not you clear the caries out of these restorations, seal them up with a well-sealed composite or on GIT, whatever you're planning to use. You can remove that stimulus and then allow the sort of vital pulp tissue to then heal itself as well, and then it's going to prevent it getting to the point where you're going to need to do any sort of pulp treatment. Or if it's, it's recession, how are you going to treat recession? If it's, cervical wear, people over brushing, it's removing that cause and allowing the sort of pulp tissue to recover and to sell itself. So again, this is stuff people will be doing, quite routinely, getting nice contact points, make sure people are cleaning. So doing a lot of endo, I do most things under a dam, which I'm sure most people do now, especially with these sort of COVID issues. But it's just finding out that cause and say reversible pulpitis. The key things is it's short duration, it's a short pine, it's not always well isolated as a single tooth, but that's when we're looking and checking for these things. But this then can move on to irreversible pulpitis. Now, this is where histologically it's easy to say whether it's one or the other because you're looking for the level of inflammation within the pulp tissue, but you can only do that when you're looking under a microscope. So this is where we have to try and use our tests and our questioning from patients to see what level we think the pulp is inflamed to. And this is a photo that I took for I think it's an upper 6 palatal root that came out whole. And you can see here, this is tooth that's irreversible pulpitis as I diagnosed this, really, constant throbbing ache. But because it came out whole attached to the pulp tissue, you can really see that level of where the inflammation is. And it really is just sort of isolated to that coronal part of the tooth. That's where all the bacteria are. That's where they're starting to get into that tooth. And that's where, initially this inflammatory response is starting, it's happening. And that's why the patients are getting that much pain. But as you go down, as you look down the sort of rest of the pulp tissue, you'll see there's not a lot of that sort of hyperemic bleeding within that area because there's not actually that many bacteria that have progressed down to that level of the pulp. So these are in some cases the ones where you could consider things like pulpotomy just to remove that top part and then leave the actual vital tissue below it. But yeah, so we'll come on to that as a sort of management issue later. But these are the ways people come in with the sort of signs and the symptoms they're saying is this constant throbbing ache. They're getting no relief from it. It's there constantly all the time. If they're not, dosed up on painkillers when they can tell the painkillers are wearing off, they're going to want to take some more because this is, more of a constant throbbing pain within that sort of contained area within the pulp. This is inflamed tissue and it's wanting to, to expand and it can't. Loosely how it works, it's much longer in duration. It's minutes and hours rather than seconds into minutes. It can often be poorly localized. People might think it's coming from the lower and it's actually coming from the top, and that's again where doing some of your tests you need to make sure you're checking all the teeth either side. Same sort of thing, you're checking for any signs of lost restorations, but also doing your percussion, your palpation, and your vitality tests on all these other teeth, and you making sure you're doing tests that have got a high level of sensitivity to say that if you're testing a lower tooth and it's responding to cold and the pain goes away straight away, then it's a true positive, and you're not getting any sort of false negative if you're testing a tooth and it's not responding to cold. Well, is that because it's necrotic? But then you've got to make sure that that's not matching up with the symptoms the patient's telling you. So they often can be poorly localized, often spontaneous. People say it's not always got a trigger, and these are ones where hot tends to make it worse. And it's all to do with this sort of fluid movement within tubules. The heat against the water in the tubule causes it to move into the tooth tissue, and that's an area that's already inflamed. It's going to start to feel worse. Where cold has come time to help it because it's reducing some of that intrapulpal pressure that's there. Radiographically, you still might not see anything. Sometimes you will start to see apical changes, depending on how long the irreversible pulpitis has been there, but often you won't see anything apically. But these are ones that sometimes you may well see, more of the cause of what's causing the bacteria to get in there. Is it trauma? Is it caries? Is it large perio defects around teeth, etc.? So you might not see apical widening that you might be the only thing you're looking for. So if I see apical widening, I know I'm doing a root filling. It's not necessarily the only thing you're looking for when you're taking your periapicals. You're trying to see, why this pulp tissue could be inflamed, and is that reinforcing your pulpal diagnosis you've got there. And I say the treatment this is one of the ones that tends to be more of an emergency treatment, because these are ones that people are presenting to you in such a 9 out of 10, 10 out of 10 level of pain. You want to do something for them there and then on the day, really. And that's either taking the whole tooth out, or we start looking at whether we're doing pulpotomies and pulpectomies, and that often will be governed by what sort of time you have available to you in some instances. But also currently there's some more research going on about when pulpotomy is going to be sufficient alone, and we're trying to leave this sort of area of uninflamed tissue and just take out the inflamed tissue. And I know Dominic Ricucci's doing a lot of stuff. I've been reading some of his papers and seen some of the webinars he's done, where he's really just trying to, under high magnification, remove that inflamed tissue and just keep assessing under microscope and seeing, is it still bleeding, how's it bleeding? And there's a lot of research he's doing now and seeing how much of this pulp tissue can we leave. But I think in a lot of instances, people are probably more likely to do pulpectomies. And then again, it's removing all that pulp tissue, but it's whether or not you have the sort of time available to you to do that, at the emergency, or whether you're going to think, right, if I can just remove that top part of inflamed tissue, get a dressing in here, this can get this patient out of pain, and then we can then look at schedule and plan to do the rest of that treatment. So again, one of these causes trauma. This person I saw, quite a few hours later, and you can see the pulp tissue is already kind of pushing itself out of the chamber there, and it's going to be contaminated with bacteria. But there's chances there that if we were to be able to place a well-sealed restoration, could we just remove that initial inflamed tissue where that bacteria has only progressed to? We may well have been able to seal that, but in this case we didn't, because we were going to need to use something like a post to restore this tooth as well. So actually we needed to use that entire pulp space to try and place a post, etc., in the tooth. So in that case, it wasn't quite as important. And then we've got so the tooth here, which is presenting with irreversible pilotis. We're checking there's potentially something going on apically, but we can see there's quite a large area of caries beneath the failing restoration distally, and that's getting into and close to the pulp space, and that's what's caused this level of irritation that's in there. So we'll have done, like I think I'll probably have done an access at the time because he presented for an emergency appointment as opposed to pain-free, but over 2 visits we'll have cleaned it out, completed the root filling, core, and placed a temporary crown over in this case, so then it can go back to its referring dentist, because it's already quite a heavily filled tooth, and I get taking stuff on referral, I want to make sure I'm sending things back so that the tooth's protected. So whether you're putting ortho bands around these teeth, or whether you're placing temporary crowns or overlaying direct composites, in this case I've chosen to do a temporary crown and send that back to a referring dentist to do the permanent crown at a stage. And then we have cases of pulp necrosis, obviously the sort of fourth pulpal diagnosis. Now again, these may or may not be painful. Often some teeth will just meander out of life and die, and sometimes it's where teeth have had very deep fillings, and just over years bacteria have just gradually got in there, and it's just been a slow process and the pulp's died. Sometimes it can be a result of trauma. If someone's had a luxation or something to a front tooth, but it's been repositioned, or it's concussed but it's severed the blood supply, those teeth may not die straight, you may not get symptoms straight away, but you may find over time, and these are often the ones that we will start to see things on a radiograph. You can't see it too clearly here, and I think probably if I'd taken a second image we might see a little bit more, but when we've got sort of thick buccal bone, you're not necessarily always going to see it. And these are the ones where your vitality testing is really important. If I'm using endofrost, -50 and this tooth is giving me absolutely no response, this patient will have presented with just like a low level of just grumbling, a bit of an ache, and just think, well, I'm having this on and off pain. It's never too bad, but I'm, temperature's fine. Sometimes biting on it's a little bit sore because we're getting a little bit of inflammation in the apical tissues and the PDL around the tooth. And so these are where really your vitality testing is really useful, whether you're doing it hot, cold, electric, or all three. Just really trying to improve your sort of the sensitivity of the test that say, if there is disease there, is this test telling me yes, there is definitely disease there? So we're trying to reduce the number of false positives that you might get. So you may well get winding on a radiography, but you may not see it. It really depends on where it is in the relationship between where the root apices to the thick cortical bone, or whether it's out of the cortical bone. Sometimes these are the ones, if it's not clear on plain films and from some of the vitality testing that you're doing, if it's an older patient who's got a lot of receded pulps and none of the teeth are responding to pulp tests, but they've got this low level, these are the ones sometimes where you may be thinking taking something like a cone beam could actually give us a little bit more information. It may show us definitely there is some element of bone loss around the apices of one or more of these teeth. And again, with pulp necrosis, you may start to see failing restorations as well. Often these are the ones I think people have come in and had really big restorations. They sort of chipped a cusp and you think, okay, right, we'll just need to replace this restoration. But you do a vitality test, it doesn't really give you any response. Think, actually, maybe if I take a periapical here first, rather than just putting a filling in the tooth, you want to make sure that, you know, you're seeing signs that the tooth is definitely not already dead. Because if you then put a filling in it and the patient says, oh, I had no trouble, you've then put a large filling in this tooth and now I'm getting this constant grumbling ache. Well, it may well have been that tooth was already dead and you just, you know, you didn't know because you hadn't done all the tests and hadn't taken sort of, you know, full PAs. You might have just gone, oh, I'll just repair it. But it's always worth, even the ones that aren't presenting with a great deal of pain, but if you see big, you know, failing restorations, you know, do some of these tests because it will sort of help guide you. And you can then say to a patient, oh, I know you're not having any pain, but that's because this tooth is dead. If I just put a filling or a crown on this tooth and then it flares up straight away and you start to get this still from an ache, you know, you've sort of consented them and warned them of that beforehand and said, actually, I think it might need a refilling, or, you know, you've given them much more information and they've been able to make that decision about whether they're going to do refilling or whether they want to risk just going straight for restoration. But if it is pulp necrosis and you've diagnosed it and you say, no, this is definitely it, these are often ones where it really depends on the patient's level of symptoms about whether you feel you need to treat it in that emergency appointment or whether they go, oh, it's not too bad. You might be better off actually just scheduling them in to do, you know, a longer appointment and actually have more time to really clean out that entire area. Because in an emergency appointment for a necrotic tooth, you really want to be cleaning right to sort of the APs and cleaning out that entire area. Whereas something like an irreversible pulpitis, if you're removing the majority of the inflamed tissue, that's going to help with all the patient's symptoms. But in something that's, you know, got necrosis, you really need to be cleaning out that entire space. So often these ones I don't just try and quickly do, you know, emergency treatment unless the level of pain is high enough. These are ones I'm more inclined to say, no, for me to do this well, we need to do more cleaning, and then, you know, check your diaries and, you know, make sure you can kind of get them in within a reasonable time period. And again, I think this is a really long tooth, this one. You see, it's, I think it was like a 29 mils. It's a long tooth. But you can see a little bit more clearly on that image, just from a slightly different angle, where we do have a little bit of widening of the laminar space, but I think it's purely just because the angle is taken out, we're just seeing a little bit more. I'm going to say we'll come to the sort of periapical diagnosis. Now, some of these will match up with the pulpal ones, and it's always what you want to make sure you've got whenever you're seeing someone for an emergency and you're thinking this is an endodontic issue. Make sure as you're part of your clinical notes, your diagnosis, you've got a periapical diagnosis and you've got a pulpal diagnosis, because it really is going to guide how you're going to do your sort of future treatment and what you're aiming to do with that treatment. Yeah, some things will be asymptomatic. These are the ones that patients sometimes are unaware of. These are sometimes things you'll pick up on your radiographs, or as I said before, this is a patient who's come in with lost a filling. They just want me to, you know, oh, I just need a new filling. I've done some vitality tests and it's given me no response. Rather than just taking a biowing, I'm taking sort of full periapical. And I start to see there's some widening around that space. And then this is when the conversation changes from, we're just going to put a filling in this tooth, to actually, if we just put a filling, you're going to have some issues. This is where we need to have more of a conversation about doing a root canal treatment to prevent you then getting that level of discomfort, and make sure that, you know, you're doing the patient, you know, a good service. Because it's never nice when you do some treatment and then you find that the patient come back a week or so later saying, oh, I'm having you know, some issues with this tooth now, and then they might feel it's more of your fault for, you know, even though it's not. But if you've told them that from the outset and you can tell them, you can send them to it, it's a bit better. But because these things again are asymptomatic at the point of your, you know, examination and discussing, then you're not necessarily having to do this in an emergency appointment at the moment, but you do then want to make sure you're planning to do the side of root treatment rather than just a simple fill-in, let's say. And again, if you can get that restored, composite restoration initially, and then plan to do a crown for a tooth, you know, soon afterwards, once we're happy that symptoms are settled. Then we can get, this X-ray's got a few bits going on it, but this is an actual patient presents with symptomatic problems, and this is, you know, you can get symptomatic apical periodontitis with irreversible inflammation, and you can also get symptomatic apical periodontitis with a necrotic tooth. It's, you know, it's when the patient is starting to get symptoms around this tooth, and this is when you're biting, they're feeling it. In this case, it was a necrotic tooth and symptomatic apical periodontitis, and so biovitality testings aren't showing me anything in the sense of hot, cold, electrical tests, and your radiograph you take, and it's quite clear that there's, you know, there's a significant lesion around there, and that's why it's tended to bite on. And again, often I'll, you know, palpate around the tissues, and if you feel in the buccal sulcus, that's when I'll feel, oh yeah, that tooth is a bit sort of tender when you're pressing in that area. That's just because there's sort of expansion in that area. And these are ones which are a bit more kind of low level, dull throbbing pain. Again, you might not need to do anything in that immediate point when you first see them. It depends on their level of discomfort that they're getting. But if they're saying this is, you know, really getting to me, and that again, maybe when you want to try and open this tooth up and try and clean out as much of this space that you can do within there. But again, with some of the symptomatic apical periodontitis, you might not see something lesion on a radiograph. You might not see a lesion there. It may be that it's irreversibly inflamed and has symptomatic apical periodontitis, and it's quite recent. You're not going to see anything because it's not had a chance, for the level of bone loss to be picked up. But certainly when you're tapping on it and you're feeling around it, the patients will sort of let you know and feel it. So that's why it's, you really want to have both these diagnoses, your pulpal and your periapical, because it can have an impact on what you want to do. And then the other type of issues as well as periodontitis is abscess. And again, some people or patients definitely use the term abscess quite interchangeably when any sort of root filling is involved. I've got an abscess, etc. But really, as a clinical diagnosis for ourselves, it's chronic or it's acute, and it's that peel and inflammation within in space. If it's chronic and been there a long time, often you'll see it and it'll present as a little sinus on the side of the tooth. And again, some patients may say, oh, it's been like that for years and never any problem. It just fills up, it pops, and it's fine. But it really is going to start leading your conversation and also how you're planning to kind of treat this tooth. It's often not an emergency in the sense that they're getting huge levels of discomfort because that infection and that pressure has found a way of draining from the side tooth. But in something like an apical abscess, the tooth is always going to be, apart from it's a multi-root tooth, it's going to be a necrotic tooth, or it's going to be a tooth that's previously had a root canal treatment. So the patients aren't getting a hot and cold symptoms because there's no inflammation within the pulp tissue. And that's why often these things can last years and linger on, and patients don't really get that many symptoms from them. But when you see it and you know it and you can take a radiograph and diagnose it, you've got to tell patients that this is what's going on, and it's not it's not normal, it's not ideal thing that you want to be leaving there. Some patients may choose to, but you've got to make sure you're informing them, and also the ongoing worry that if you leave it and then the tooth does fail, it can affect potentially implant options, etc. down the line, and actually the level of bone that you might be losing in that space. Sometimes you'll also, when you see on your radiograph, you'll see the lesion. It's not always a lesion because sometimes the infection is not pure and it's found a way of draining and it hasn't created a large area of bone loss. But sometimes you will. But what you may also see is large caries restorations, sort of caries around restorations or failing crown margins. Those are the things that you can sort of see there as well. And as I said, possible failing RCTs. Now, this one I've removed the crown. I think I've just done a simple core build up and I've just dressed it for a couple of weeks, just because I wanted to make sure that I think it had been quite long standing that was going there. And so that's just prepared for sort of to have a crown made on it soon. At the moment, it's just got dressing, and then a second visit I would then finish that. But you can see how much the sort of the body's ability to be able to heal, and that's what I really love about endo in some senses, that when our treatment is successful, the amount of bone and tissue and the host response that we can actually regenerate and grow and get back to sort of full health, I find quite good. And especially he showed some periodontists how much bone that we can grow at the apex of the teeth, and they're doing all the sort of grafts, etc., to try and get bone back. And we get it routinely when we're doing our endo, and even surgical endo, we're seeing if you cleaned out and removed any source of bacteria, you just left blood in that bony crypt, and how it heals is that's what we're aiming for, and that's what we want. And then hopefully you're not seeing too many of them, but we may well have had phone calls and had to refer these on to urgent care centres. This is when you have patients who present with a large area of swelling. And this one was a guy I saw, and he had 4 linked crowns with RCTs that had been there sort of like 10 or 15 years. And his whole face and upper lip was outswollen, and all the soft tissues are really large and inflamed as well. And this happened sort of overnight. It was just like, I felt a bit tender, and then boom, it's gone. And it's just that, spread within soft tissues, and it's not found a way of draining. And these are the ones that really are an emergency, and you've got to try and do something, quite quickly for these ones. It's spontaneous. Everything for those tender, touching in any of these 4 teeth, because they're all linked, all the soft tissues. And again, you don't need to, if you can see this tissues that inflamed, you don't need to be pushing and palpating really hard to confirm that diagnosis. The patient's in discomfort, and you don't need to be smacking on these teeth with mirrors to tell you these things as well. So yes, you've got to go through your sort of routine, but you can adapt it a little bit as soon as some of your extraoral, intraoral, and the questions and signs you're getting lead you in a certain way. it really does help. And then taking the radiograph, we're getting even more information. We can see radiolucencies around the apices of all 4 of these teeth. So now it's a big conversation with the patient that, any one of these 4 teeth could be what's causing you pain. At the time, I think we just opted for some incision and drainage, as opposed to trying to an emergency appointment when he's got such heavily restored crowns. I don't know exactly what's underneath there, to try and access and get root filling material out. This is a longer, a lot of treatment, a long appointment in an emergency when there's a acute, apical abscess and swelling. It's trying to gently numb up some of these areas and actually get some incision and drainage, try and get some of this inflammation in the soft tissues out. Or alternately, you could consent for patients who say no XLA, then again, extraction it's definitely going to solve the issue of the acute apical abscess, but it's maybe not going to give the best long-term option for the patient, aesthetically or functionally. But these ones are something you need to. I think this gentleman actually tried incision drainage and then cleared some of my diary the next morning or something to get him in and try and get something sorted, because it's quite urgent. We need to do something here for him, especially when there's so much going on. You can sort of see in some of the soft tissues, everything's inflamed, so I don't know if this is just purely because of poor oral hygiene, or whether you see around the upper right too, on the left image there, you've got sign of swelling and almost pointing in that area. But yeah, everything was just so inflamed. And then this is as we start trying to deconstruct stuff. This is why you can't necessarily always rush these things, because you can see the size of we're trying to section and move these things carefully without damaging the preps underneath. But the amount of sort of luting cement that's in there, and I think the next image you just see everything's just super inflamed. But once we can get this off, we can then start trying to get in and clean some of these areas. And this image again on the palatal side shows where some of the access cavities have almost been going in horizontally, some of them more on the incisor ledge, and so it's a bit of a, and you can really see where the swelling is around the upper right too on this one again, where it still really inflamed tissues. And so the emergency management here is obviously very, very different, and you just need to make sure you've got sufficient time to actually do this carefully, properly, not damage anything underneath, and then get the gentleman in some temporaries as well once all the bleeding's kind of reduced a little as well. So, but it's going through that sort of pathway to get to that point, and then really trying to manage it appropriately with the patient. Vitality test, I say, is really a key thing, and the sensitivity and specificity of a lot of the tests that we do is actually really good. Certainly, cold testing, endofrost is my sort of first go-to one. If someone says they're having really deep ache, but temperatures aren't affecting it, then I want to test it with cold first. And if I'm not getting any response from one tooth, but all the other teeth are responding, then I'm quite happy that this has shown me signs that it's possibly pulp necrosis. But if nothing's responding to cold, then you think, well, I wonder why is that? What else can we do? Can we try electric pulp tests, or do we then have to move on to other ways of testing and looking for things and trying to confirm our diagnosis that way? HOT's a really good test. Sometimes it's a little more tricky to do. If you've got some of the warm vertical sort of down packer tips, they're quite good at creating heat. Sometimes you just have to, if you've got some GP pellets, sometimes you can heat those and place on the tooth. Other ones is trying to put a rubber dam around a single tooth with some warm water and put that around a tooth. But it's more tricky, but there are ways to do it. Electric pulp testers are great as well. Sometimes you want to be doing cold and electric just to give you, a bit of reinforcement that you're getting the same response with both, and it's not just a false positive or a false negative. And before doing any of these things, you want to be, discussing it and explaining it to your patient as well, and telling them what you're testing for and what you're expecting to feel. So if I'm using cold, I'll be saying to the patient, right, okay, I'm going to test them with your teeth. The normal response is this: you should feel a cold sharp sensation. As soon as you do, make a noise, let me know, I'll take this away. We then want to see how your tooth responds. If it responds, within a few seconds, you feel no pain, that's great, that's what we're expecting. If you don't feel anything, that's also fine. Just I'll hold on for 30 seconds or so, and then we'll take off, and you can let me know what you did feel. Or if you get a really sharp response, you want to make sure I'm taking this off straight away. I'm then going to put my finger on it just to try and warm it up again to the patient. But let them know so they're kind of expecting it as well, especially when the teeth is kind of acutely irreversibly inflamed. You don't want to just do it without forewarning them and apologising beforehand, saying, look, I know this is going to be potentially quite uncomfortable, but I want to let you know because this is going to confirm that we're doing the right thing. And again, with the electric one, that's often quite subjective. I don't know if any of you tested on yourself. It's a bit of a strange feeling that you feel through, through the tooth. But try and, inform them that's what you're going to do, and you're going to test a number of teeth, and sometimes do them in different orders, so a patient can't sort of. Some patients will tell you what they think you want to hear. So sometimes it's trying to sort of use your test appropriately that way. And so radiography, I mentioned, briefly long cone periapicals. Sometimes it's, really useful to take one from a second angle. So you're not just seeing it sort of from one image. You can take one from a second angle and use this sort of parallax and see if you might see a bit more. It just all depends on what the beams are going through and how it's getting picked up on the sensor or the film on the other side. And again, some resolution of certain films are better than others. And there's some of these digital sensors, but some places they use the phosphor plates. And you still see some stuff, but digitally you can certainly manipulate your image a little bit more. DPTs, if you already have one and then you take a PA, you can compare it to it, but I wouldn't use a DPT routinely for endodontic diagnosis radiography. But then cone beams are really, really useful, and certainly with the newer machines and being able to change the parameters of them and really trying to sort of hone them into what you want to see. Smaller 4x4, 5x5 cones, you can keep the dose really, really quite low. But it's going to give you a load of information, and it can really impact on your conversation you're going to have with the patient, and also how you're going to approach your treatment as well. Because this lady who presented it, she had two, RCTs done on both his teeth. Both look, pretty good on the whole, quite close, within sort of 1 to 2 millimeters apex. 6 has obviously got a really large NIR core into the canal area, so I think, well, is that tooth potentially cracked, or was like that beforehand? If it is that tooth, how are we going to, treat and temporize that tooth? It's a lot of work to do that. Or is it the 7? If it's just the 7, or is it potentially both these teeth? So this is when I had a discussion with a patient. I was like, look, it could be one or two, many of these things. We could try treating the most obvious one, the 6 first, because it looks like something is happening on the distal root of that 6. But if that doesn't, resolve the symptoms, do we then start looking at the 7 as well? And then how confident that we're improving on things? And this lady doesn't like treatment. She doesn't want to sit for long periods of time, which again is going to mean that, well, trying to treat that 6, if we're going to have to take the crown off, take the post out, redo the root filling, and then redo the post, redo the crown. That's a lot of treatment to kind of go through. So this is one where I took a cone beam, and again, this shows us so much, more information. That the top left image shows that top left, as I'm looking underneath the radio from radiography, shows us a lesion on the mesial root of the 7, so we know that 7's partly to blame. But it also shows us that there's an extra additional root distally on the 6 that's got a lesion on it as well. So we know that actually it's the 7 on the 6. So we can't confidently say to the patient, right, we'll do one, we'll do the other one. It's like, right, actually, if you want to try and maintain and manage both these teeth, potentially we're going to have to look at treating both these teeth. Now, yeah, 7, we might have just been able to treat the mesial roots, the left the distal roots, and the 6 as well. Or could we consider surgical options? But with a whole missed root, then again, it's tricky. But for this lady, she opted that it was all just too much work for her. She didn't want to do, the 7 and the 6. She just didn't think she was going to be able to tolerate and manage that. Her level of discomfort she felt manageable at the time, and she just wants to leave it for now. She's aware there's an issue. She's been fully informed. She's been shown scans and tried to have it explained, because although we get used to her seeing it, she might not completely understand it. And then she's aware that if it gets to the point, she's going to have whichever tooth is symptomatic taken out, and then she wants to consider her implant options for those cases, which is fine for me. My job is there to sort of explain, show, and this level of treatment you only want to do on a patient who's really bought into the treatment and understands that there's risks, understands that these teeth are heavily restored, there's risk of crack. I could start taking things apart, and if we didn't have a cone beam to do that, and I had to just start treating one tooth at a time and taking things apart, then I see a crack, and then I manage that tooth and then move on to the next tooth. It saved me a lot of headache and clinical time from the outset, and then see impacts on how you sort of charging and et cetera as well. So being able to take a cone beam scan just really improves that sort of ability to kind of see some of these things. And it's not just for cases of retreatments. Some people are taking them a lot more in like normal cases, and certainly pre-surgical cases, because every time you see one, you always find that you're getting a little bit more information. You're seeing something, and it often will impact on how you treat a case, whether it's not you're seeing second curves in canals that you didn't appreciate or didn't know that were there. And it can really speed up your management of a case and how you can actually schedule your time, schedule an appointment, whether you're going to do single visit, 2 visits, which is another whole issue altogether. But the ability to take a cone beam is really good now. No, everyone's going to have the option to do that, but there are practices nearby you, and if it's not a complete emergency and you've got a chance to do that and get poly with your, if you're in with the practice that does do it and can report on it, then cone beams are really good, and I think something that we'll certainly be seeing a heck of a lot more of. So this is how I kind of, this is some software called Kuroku. I've been using it for a few months now, and just before lockdown, and I find it really useful, partly for myself to make sure that I'm going through all my questions correctly, or going through things, but also the nurses that I work with on a regular basis can just sort of click on any, as I'm having my usual conversations or discussion with a patient, they can be clicking through a lot of these things, so I'm having to sort of type a lot of things down, and it just gives me a good system and an order, and anything that I've missed, if I go back and when I check on it, I'll be like, oh, actually, I didn't have that on, but it was for this reason that I could see this. And it just kind of makes things very clear for me that I'm kind of following a bit of a pattern. Then this is when we sort of select the onset, is it sharp, where you can throw in burning, what special tests have I carried out, percussion, how the teeth notched and the arch, which teeth I've tested, palpation, the endo, frost, etc. What radiographs I've taken, what I've noted on, radiographs, any other findings that I might have found. Is there deficient restorations? Have we got widening? Have we got root fractures? Have we got unusual anatomy, which will often mark down? Because again, when I look back and before I see a patient, it's going to affect how I'm going to approach the case. I was assessing a radiograph before I go in and do anything. How am I going to make this as efficient for the patient and myself as I can do? Am I seeing any fractured instruments, etc. if it's a retreat? And then working onto my diagnosis, then again, I can then click and, this is pretty, hot on this sort of stuff now. They know from the questioning what it's likely to be. And again, it's something that's good to go through your nurse with your sort of your chair-side assistant, your nurses, because then they can often, populate a lot of this sort of thing. And then when you finish doing your consultation, it's saving you a lot of time to kind of go through, and you can kind of get on a lot more with what you're doing. This is again, just briefly, just to touch on some of the non-odontogenic stuff. So if a lot of the tests that you're doing aren't marrying up with what you're seeing and radiographically what you're seeing, this is when you start thinking, actually, is there something else going on in some of these cases? Because there are, lots of different things that can cause it. Typical ones I seem to see more are the kind of musculoskeletal and the neuropathic ones. So TMD issues, you're checking jaws, muscles, etc. How has their pain history been over the years? Have they had similar sort of aches and pains in the past? Has it been referred? Is it, jumping all over the place? How well localized is it? Have they got any history of sort of headaches, migraines, any anxiety issues? So you're going to take a full medical history, because a lot of these things can if everything's not matching up the way you'd expect it to and what you'd usually want to see, it's one of the good things just to sort of have that second thought in your head, like, could this be something else? Get a second opinion. Now, ask whoever you refer to, referring dentist, normally before potentially referring the patient through. I've got this, and this. I think it's this, probably this, probably, but it's just not matching up. Speak to colleagues. That's when it's quite useful, because sometimes you get yourself kind of very set down what it could be. You just want to have a chat with someone else, and they may say that it's potentially something else. I say there's a little bit just about emergency treatment at the moment, which I think is probably even quite useful as people start getting back to work, especially in the UK, because there's a bit of a backlog of people, and we may have to kind of prioritise who is more important, especially if you're triaging by phone. If you want to be trying to plan just to get them in and do an AGP rather than get them in for an assessment and then the AGP, if you can plan it and kind of glean what you can from the phone, then you may just be able to help them, but these patients out a little bit quicker. So the ones that I see as sort of out and out emergencies that you kind of need to do something for the day is symptomatic irreversible pulpitis. The constant throbbing that people feel they're going to, they want to rip the teeth out themselves because it's, so sore, it's constant pain. That to me, you want to be trying to do something and numb these areas up, get this tooth, access dressed. Symptomatic apical periodontitis, so be it a necrotic tooth, a previously root-filled tooth, a pulpitic tooth, if it's, they've got that level of pain, discomfort. And again, this comes to the conversation with the patient. If you say, look, I can do some emergency treatment now, it's not going to be ideal, it might help a little bit, or I've got a space in 2 or 3 days, you can manage the pain relief, and then we can actually get more of it during that time. But again, that's still managing that short time. And then your acute apical abscess, the facial swellings, they're again something that we need to kind of be treating with quite urgency, because we all know with swellings, it can affect the airway and become life-threatening on that side of things. We've got to make sure that we're finding a way to get some drainage, be that incision and drainage, or be it through the tooth itself. And if you can get it drained through the tooth, happy days. But it all depends on how long it's been there, really. So the BES at the end of the site have got a suggested sort of access protocol for the moment during the sort of COVID. They kind of released this, and yeah, it's getting the tooth numb, getting a rubber dam on there, accessing into the pulp chamber, extirpating, dressing, and then post-op, which sounds really easy. But a lot of the time these things aren't always easy, because if it's an emergency appointment, it's sort of squeezed into space. Think, oh well, I'm not going to be able to get it, properly numb, or well, I won't bother putting a rubber dam on because I need to save some time, or you rush the access and actually you've not spent the time assessing the radiograph first to go, is this going to be an easy access or is this going to be a very difficult access? Because if it's going to be a very difficult access and you've only got 10 minutes, are you doing the patient a service by just trying to do it and end up causing some more iatrogenic damage? Or could you actually go, right, well, actually I do need more time. Can you change things in your diary, or can you look at things next door? Can you speak to colleagues and see who can get it in sooner? Pulp extirpation, well, obviously if it's necrotic, then that's there's no pulp to extirpate. So is that when you're going to rely more heavily on how much sort of shaping and cleaning you can do and what dressing? Or if it's irreversible, you're just trying to remove that inflamed portion of tissue at the top. If you haven't got time to do a full pulpectomy, then don't worry about getting files down the teeth. Just think, well, actually, if I can just unroof this, take out that mainly inflamed coronal part of the tissue, and get a dressing in there, that's going to calm things down quite a lot for this patient. And then only start introducing files, etc., when you've got time to appropriately clean it and manage these things and make sure you've got a good well-sealed rubber dam. You're using strong hypochlorites, sodium hypochlorite to actually kill that tissue. And again, some of the dressings people often discuss, where using Ledamix, now that you can use it again, or using Endodontic paste, where using calcium hydroxide. So although it sounds quite simple, you've got to have a little bit of a plan in your head about how you're kind of approaching some of these things. Some of the other guys in Newcastle, Andrew Gemmell, and the guys at the dental hospital did some research saying that routinely for endodontic procedures in part of the Northeast, from a questionnaire of the people that responded, 57% of people said they weren't always using rubber dam for disinfection or obturation, which is really high, and that's of the people who actually responded. So there's a good paper Andrew did, and it just got published, I think, in the BDJ sort of March, April time, that kind of looks at that. And I think rubber dam is just practice, and I know a lot of people who kind of logging into these webinars are probably the people who do tend to use it more often than not, but it's just practice getting used to using it, because it will make your life a lot easier. And especially in an emergency, if you're rushing, I think if you can spend a minute to put a rubber dam on, you'll find that the rest of the appointment goes a lot quicker, because you're not kind of panicked having your hand clamped there, worry about what you're using this irrigant, that irrigant, or what can you see. So you get proficient using rubber dam, it definitely helps. Again, this is where I mentioned that is it pulpotomy or is it a pulpectomy? Now, as I showed you that picture, the majority of the bacteria are going to be in that coronal part, so you really just want to be removing those, and that's going to sort of stop that inflammatory cascade that's going on inside the tooth. But if you have time, and at the moment, if you've got time and you put them in, well, there's no point. If it's an irreversibly inflamed tooth, there's not many bacteria there. If you've got the time to do the full root treatment, obturate it, seal it, then even better, because although we think we do great temporary fillings and dressings, there's a chance that could leak, especially if a patient's not going to be back in for a few months, depending on what happens, if it's lockdowns, etc. If you've got time to get it, even if it's irreversibly inflamed tooth, get the whole thing done, happy days, because you've really reduced the opportunity for more bacteria to get in there, and especially if you've got rubber dam on and you've got sodium hypochlorite in that top part of the pulp, it's going to really sort of reduce the number of bacteria that you're having to clean out, because that's the whole aim of what your root filling is doing. It's disinfecting and cleaning bacteria. So if you can reduce the number that are getting in there from the outset, even better. And again, the BES, the British Endodontics, said it really should be using 3 to 5% sodium hypochlorite, which is widely available from a lot of the sort of dental suppliers and things now. But yeah, you need to make sure it's in there, and you're really trying to use a high enough strength that it's actually going to be effective at what you're trying to do. The thing she mentioned, I think, is dressings, and there's not great evidence that say one dressing is better than the other, because I think it's quite hard to do a good evidence-based trial that will show you one is better than the other. The way I tend to do it is, if it's irreversibly inflamed and I'm not removing all the pulp tissue from that space, then something like Ledamix or Odontopase, because it's got a steroid in it, it might calm things down a little bit more. So I'm more inclined to use Ledamix or Odontopase. If my diagnosis previously is pulp necrosis, and it's had symptomatic periodontitis, or it's had a chronic apical abscess, then I'm more inclined to use dressing with non-sodium calcium hydroxide. So there's Unical and Calciplast. There's lots of them, and also you want to be able to try and get it down to the sort of apex side of the tip. So the tooth. So I tend to use something that's that's got one of these long, sort of fine, flexible points. This is a pre-ball that actually got 2 complement canals, so this is quite a nice one to see that you're actually kind of getting into these areas, but you're kind of filling that space with it. Because I think sometimes if you're just using it from the hypercal syringe and just trying to dot it on the top, it's not actually getting into where you want to get it. Whereas if you can use these long sort of fine tips and actually syringe it into the space, we're wanting this calcium hydroxide to be in contact with any bacteria, and that's how it works. It just free radicals and breaks that. That's how it kills bacteria. But I say, if you look for really strong evidence to say one better than the other, then it's hard to find that. But I'd say irreversible or inflamed cases, I tend to use steroid-based one if I haven't removed all the pulp tissue. But in a necrotic case, I'll tend to use more like calcium hydroxide. If you don't have Ledamix or Odontopase, calcium hydroxide is still going to work well in an inflamed case. But that's just the way I kind of reason it. The other one, so the final bit, I just want to go over is, complications for emergency treatment. So what people find hard in emergency appointments and treatments, and I think often it is, a lot of these lead into each other. It's getting things numb and having the time to allow things to go numb effectively, but then also having the time to do it. And if you feel like you're jumping, and you can't do it at the moment, swapping people in and out of the clinic, in and out of surgery, which you definitely can't do with all the current restrictions in the UK about fallow time and AGPs, etc. But a lot of the LA difficulties is just time, and especially if something is irreversibly inflamed. There's studies will say that lower molar teeth with irreversible bites are more difficult to get numb than other teeth. There are some studies that say mepivocaine is better, but I think a lot of the time we kind of blame ourselves if we haven't got a tooth numb and say, oh, my IDB mustn't have worked, or I haven't done this properly, But sometimes the teeth are going to be more difficult to numb. It's not necessarily you've done anything wrong if your IDB has worked. If you've done an IDB initially with, I would use lidocaine, but some people will use articaine to do IDBs. Or some people are quite against doing that. But again, that's an option. If you then also done your buccal infiltration with lidocaine, with articaine, that can increase the success rate of the LA quite a lot. And then if you've got availability to it, intraosseous anesthesia is definitely one of the best ways to get things numb, and has really got a really high success rate, but not everyone's going to have availability of intraosseous. But I would say just don't be too hard of it if you can't get a tooth numb and it feels like it's really inflamed, because sometimes it is just more difficult. Yes, if you have time and you can leave it 10-15 minutes, it may be more numb. You may be able to just get into that pulp area just to sort of release a bit of that pressure, dress it as best you can do, but you can place intrapulpal LA at that point. But you really do need to tell your patient it's going to be pretty sore as you do it, but it will help them and it will get things more numb. And it's just a sort of, a question of, and each individual, how much you think it's going to be uncomfortable. Time, again, I say a lot of these things will be squeezed in your regular practice. At the moment, it's a bit different because we can triage these things, and so hopefully you can plan your time a bit better if you know it's going to be one that you want to access and dress. But usually time is often the issue when you've got to try and squeeze it in around people, and I guess maybe it's just trying to organise your diary and contact people later and say, oh, we've had an emergency, would you mind rearranging, etc., just to try and do a bit more. And then case difficulty, these ones I say, if it's a really sort of old sclerosed tooth, or it's been previously root filled, they're going to be more tricky to try and access and get and do anything for. And a lot of it is just actually spending an extra 30 seconds just looking at the radiograph first, measuring things, knowing where you want to go, angulations, tooth, is it tipped, where is it, rather than just being in a rush and just firing straight in with a burr and go, right, okay, I've just got to get into the pulp, because you can end up getting yourself lost looking and then you lose some of the anatomy. So just kind of assess it and look and see how difficult is it going to be. And then see, if you think it's appropriate to do, or if you don't, then you sometimes it is better to say, "Hello, yes, you're going to be in pain for another day, but I've got more time tomorrow. I think it is better that we do it then, and I can do a lot more for you, and it's going to help you." But that's just obviously depending on how the patient finds it and what kind of discussion that you can then have. But yeah, that's everything. I think it's really just always sort of go through your kind of your sort of system that you probably would do generally anyway, but really try and sort of focus on your pulpal diagnosis and your periapical diagnosis. A lot of it you can sort of start to glean from your history and take a good history, because a lot of the time, a lot of these things patients will actually tell you, especially when it's in relation to sort of temperature, what the feeling's like. A lot of it, if you just spend a few more times asking a couple more questions, you'll get a lot more further down the sort of pathway of what it might be, and then your tests and your radiographs, etc., are just going to give you that final yes, this is what I'm expecting to see. And then just with your emergency treatment planning at the moment, just a bit more time just assessing and think, right, what am I aiming to do, what am I trying to do, rather than being like, I've just got to access and address this. Think, well, actually, what's the current disease process? What are we dealing with bacteria? Where are we dealing with bacteria? And how am I expecting to get them and sort of clean them from that side of things? But yeah, I think that's everything. We've just gone over the hour, but I'll stop sharing my screen there now and see. I think there's been a few questions come through. Louise, are you still there? How do I get the Q&A?
Hi, Tom. Yeah.
Got it.
So can you see?
Yeah. So how do you come to the correct diagnosis if there's no obvious caries, no TTP, and multiple heavily restored teeth with no radiographic signs, but patient has symptoms of reversible pulpitis? Yeah, they're the difficult ones, because that's often when things are a little bit more vague. You just really have to kind of go through and assess tooth by tooth, do your vitality testing on all teeth, tooth by tooth, Steve, and that's when you want to be asking the patients, like, all these teeth might respond to this, but does one of them feel different to the other one? Does it feel more pronounced? Does it feel less pronounced? Like, kind of get an essence of that. Is one feeling slightly different? So radiography, you might not see anything. But yeah, it's just trying to go through tooth by tooth, assessing them, getting your perioprobe check. High magnification helps as well, so you can really sort of feel and get a real probe check margins or restorations. If they all look almost identical and you really can't see a difference between any of them, sometimes you may just have to say, look, to the patient, I don't think I can give you a definitive which tooth it is at the moment, and I don't want to do anything that is irreversible that might not be the right thing to do. So our option are, if one of them looks more likely, we could remove the restoration from this one first and see how it goes. Or you say the other option is just give it a bit more time. Say, we're going to leave it another 3-4 days. We'll book an appointment with you late this week, next week. And then I want you to keep a pain history of over the next few days, when it occurs, when it doesn't occur, are there any triggers? And then see if you can start to feel around it yourself and see if you can get a sense of it. So don't be afraid if it's really not clear. Don't feel you've got to do something. Obviously, depending on their level of discomfort, to say, look, I think we actually better waiting and seeing how it kind of develops. But yeah, they're the trickiest ones, and that's why sometimes you just have to go through your entire routine of every test. Hot, cold, electric, pulp tests, checking all the margins, checking all restorations, taking radiographs from different angles, and then sort of saying, look, we just need to do this again on another day, and then repeat the same level of tests another day and see if you start to get any different answers. Next question is, what is XLA? So XLA is extraction with local anesthetic. It's just an abbreviation that we use in the UK, so XLA is extraction. LCPA is long cone periapical, so it's just a standard periapical 2D X-ray film. And DPT is dental panoramic tomograph, so it's a panaural, or it's what other people would call it. Again, 2D. That gives you sort of, we can have half DPT or quarter DPT. So, sorry, what system are you currently using for the template for notes? So that's a software called Kiroku. It's spelled Kiroku. It's something in the UK that's, I think it's relatively in the last year or two, but it's got a bit of AI in it, but you have templates that you make and set up yourself. And so it's a separate piece of software just through Google Chrome. And then as I go through, my nurse will sort of click through and add it. And so I have different templates for treatment, consultations, emergency appointments, examinations, etc. But yeah, I think they do like a free sort of trial. You can have a look and see what you think of it. But it speeds some things up. And again, I think you can do some letter writing with it as well, which is quite good. What stage role of antibiotics give the best outcome of treatment? I typically don't try and use antibiotics if we can avoid it. I think currently in the UK we're really kind of hot on not providing antibiotics unless we can't avoid it. So anything that's got apical abscess, incision and drainage, or draining through the tooth and dressing the teeth is our first line treatment. Would only give antibiotics potentially as an adjunct. If it was a really big facial swelling and I didn't feel I was able to get much drainage, then sometimes I may provide antibiotics at that point. But routinely that we don't, and certainly nothing for it's pulpitis, etc. Then there's no role for antibiotics in pulpitis because it's not an infection that's going to be dealt with by antibiotics. But yeah, we try and sort of steer away from it in the UK as much as we can do. But I would probably in some cases where it's a really heavily, large amount of swelling, then I probably would as an adjunct, and we'd tend to use amoxicillin and metronidazole. Obviously checking there's no allergies, etc. initially. Next one. Do you attempt to restore when you see fracture lines on the floor of the pulp, or restore when fracture lines are just on the axial walls? Yeah, that's a big topic. Cracks and fracture teeth is a big one, and because you can't always see where they go, and you can't always, you probe for them and you try and test for them. You may see areas of bone loss around on a radiograph. You may not, but using a microscope is really helpful. If I see them going mediodistally straight through the floor of the tooth and across the pulp chamber, then no chance. If I see them just sort of disappearing into the coronal part of the tooth, then that's when I'll probably have a conversation with the patient and kind of gauge how they are regarding treatment. So often I'll say to someone, okay, I can see a crack in the tooth now. All I can tell you is the crack will eventually get worse, and that it'll be the reason why you lose this tooth. We may be able to refill the tooth and put a crown on the tooth, and that might get us more time, but I can't give you a definitive answer of how long that's going to take. It could last you a year, it could last you 10 years. What you've got to then ask yourself as a patient is, if it fails after a year, are you going to be annoyed that you've spent the time and cost doing this and that it's failed? Or are you going to be happy that you've given it a chance and it could have lasted longer? Because then that's really the onus is on them. That I've said, if this only lasts a year and it fails, that's not necessarily anything, unless I do something completely wrong, which obviously I'd say this in word, but then the onus is on them that they're choosing whether or not they're going to take that risk. Sometimes if you can get a sense of how big it was. If you say to them, if it was a family member, or if time money wasn't an option, yes, you try it, but ultimately it's their time, it's their costs, it's their money they're paying towards it. They've got to be the ones, and as long as you've told them quite, honestly, you're not giving them false hope, then it's up to them. But if it's a significant crack and I can see it and get a probe in it and it's disappearing, I can see it still going down the canals, then that's probably when I'd be like, no, I think it's worthless. But a lot of that is gauged on the patient. If I think it's quite a demanding patient who is expecting everything to work and they're going to come back and want a refund if it doesn't, then that's possibly one of the ones where you go, look, I don't think this is for you. I think the risk is too high. So for working length, taking radiograph is better or using apex cicator? Which one is most reliable? I would always use an apex cicator for every root treatment, because that's going to give you the most reproducible answer. Taking a radiograph, there's too many root anomalies that you might not be able to suggest. So if you see something that looks 3 mil short, but your apex cicator saying it's fine, are you then going to adjust it to meet your radiograph? And then you could end up over preparing and making it too long when actually it could have been absolutely perfect. So I would tend to always go with my apex cicator. if my APEX for some reason isn't giving me conclusive readings, or I don't think it's right, or it keeps changing, then sometimes I'll take a radiograph with a master point in or a master file, more as just to check to see, is it confirming what I'm thinking? But I would never just measure on a radiograph and go, I don't need to use my APEX. I'd always use that first. Have you ever had to deal with sodium hypochlorite extrusion? If so, what have you done? No, I haven't, thankfully. Use side vented needles, low pressure, really careful about how we, how much pressure we're using to place it. Always make sure we're short of the apex. Always make sure it's not locked and it's loose inside the canal. But really, if it were, there's a really good paper. I'll see if I can get Louise to sort of send it around to everyone's in it, because that kind of goes through stage by stage what you're doing. It's it's obviously abandoning what you're doing, flushing things out with saline. That's one of the cases where you definitely are going to prescribe some antibiotics. If you're in general practice and you've got a hospital nearby, a maxillofacial surgeon, you probably want to prep and pre-warn them and let them know going ahead. You want to dress the clean out saline, dress the tooth, and put a restoration over it. And then it's really patient management is the biggest thing there, because you do have to let them know that it's going to be quite significant what's going to happen. But I said there's a really good paper. I'll see if I can get the name. I can't remember the name of it right now. That kind of goes through that stage by stage, step by step. But yeah, it's very scary. I think that you've just got to try and, I would say, just got to try and stay as calm as you can. Patients only get annoyed if they think there's people are negligent. But ultimately that's because they feel like they're not being cared for. If you say, okay, this has happened, it isn't, it's unfortunately one of the small percentage of things that can occur. It has happened. What we need to do is we need to manage it appropriately. We need to do this, and this, and this. So when a patient, is expecting an issue, but then you've given them a solution and a pathway of what's going to happen, how you're going to follow it, you need to be confident in that this is what we're going to do. Patients will often still feel cared for because you've explained it's happened, it's not been on purpose, etc. But they've been cared for, and you've given them, a pathway of what's going to happen next, and then kind of go through that. If the diagnosis is acute apical abscess, and how and where do you place LA around the swelling? Yeah, it's a good question. You definitely don't just put it in the swelling and inject, because it's going to hurt like heck, because it's already, a lot of the pain is from the tissue is already inflamed, and if you pile 2.2 mils of LA in there, it's going to be even worse. So you really do just carefully have to kind of go around the swelling and just inject small amounts initially. And it just takes a little bit more time. But yeah, you definitely don't want to just inject into the middle of the swelling, because they're not going to appreciate it, because it's going to hurt like heck. So you just want to kind of use smaller amounts in multiple sites around the swelling, and just sometimes try and kind of massage and move it around, but a little bit slower. Which electrical pulp tester do you prefer? I don't know. I wouldn't know one or the other. I just have the one that I use, and I feel like I can't remember what the name of it is. But yeah, it's my sort of backup. I'd use cold testing first, but then electrical pulp tester is useful. But I can find out if people want to know. What do you do when the pulp is still tender or painful to file despite the tooth being numb? So yeah, they're the ones where it's kind of like a hot pulp. And sometimes you do just have to inform the patient that you're going to do an intrapulpal anaesthetic, and tell them it's going to be sore, but it will relieve the symptoms, and actually place the LA straight into this sort of pulp space. But it is sore. Or even with that, if you feel like you can't get sufficiently anaesthesia, they're sometimes the ones that you do just have to dress and say come back to another day. And if you manage to sort of unroof and release a little bit of that pressure, again, there's no benefit providing antibiotics, because it's not infection that's there, but you may want to use a steroid based dressing. So yeah, Ledamix or Odonma paste, etc. would probably help in those cases. But intrapulpal or intraosseous LA will help that. Is there any alternative to Ledamix? Is Ledamix available in the UK? Ledamix is available again in the UK. So yeah, Ledamix is available again. I don't know which supplier, but I'm sure a lot of them now. Or Odontopaste is another one that's similar, not quite as effective from anecdotal, what people would say, but yeah, you can get Ledamix again. Do you prefer using rotary endodontics? Yes, yeah, rotary or reciprocating. I mean, I definitely use hand files for initial negotiating some of the canal, but even our glide path, I tend to use some glide path files are quite good. Some high-flex ones, some tensile ones are good, and then reciproc as well, or wave gold. You know, use most of the file systems, but I would definitely use rotary reciprocating for the majority of my sort of shaping and cleaning. What do you use to remove old GP? Again, another big question. I think I'm doing a one on retreatments late this week on Wednesday, which I'll kind of go over retreatments there. But there's those things: hand files, reciprocating files, rotary files, probes, chloroform and solvents as well. Sometimes you try not to use them too much, but sometimes you have to. So that comes down to analysing what GP's in there and how well it's been obturated initially and what you're trying to achieve by getting it out. So, when you extirpate and dress with leather mix, do you only place it in the coronal pulp and not force bacteria further down the canals? Whereas for calcium hydroxide, you mentioned it's better to go all the way down the canals. Yeah, good question. I would only place calcium hydroxide, etc., down the canals. I'd only want to place that in the areas that I've actually shaped and cleaned. So that case I showed you on the video, that's one I was doing over 2 visits because it was necrotic and a sinus. So I've done all my cleaning, all my shaping, and then I'm using that to place it right to the very end of the canal. But as you very rightly say, if it's pulpitis and you've just cleaned the coronal part of it, but you might not have cleaned all, there's some bacteria in there, you don't want to then be getting files and trying to push leather mix, etc., down there if there's potentially bacteria in that top part as well. So if you're not used any files, etc., and you've just really removed the coronal pulp with an endo Z there or something, then it's good just to sort of place it in that initial top part of the tooth in the coronal space and just let the medicine do its job and work there. Yeah, if it's pulpitis, you definitely don't want to be forcing stuff. But say calcium hydroxide, if you've cleaned and shaped that entire space, you want to essentially fill the space or get that calcium hydroxide to be in contact with potentially any of the bacteria that you feel that may still be there that you wanted to try and kill. So that's why you need to do it down. Where do you practice if we need to refer to you? Very good question. Thank you. I'm in the northeast of England, so in Newcastle, but I work across sort of 3 practices. One's in a place called Gosforth, which is north of the river, and one's in a place called Lanchester, which is just in County Durham, outside Durham. So one's called Westlands Dental Studio, one's called Grange Dental Centre. But I'm sure if you Google my name and endodontics, it'll probably come up there somewhere. But yeah, I think that's. Is there anything? Yeah, that's all the questions there. What size of gutta percha do you use to trace a sinus tract? Just the smallest you've got that you can get in there, really, or the biggest you've got that you can get in there, really. But I would probably try and start with something pretty small initially, to see if you can trace a sinus tract. But that's actually a good point that I did put in there. There is a sinus, and you're not sure which tooth it's coming from. put a GP point inside through the sinus tract, and that'll definitely get towards point more likely at a tooth. So again, it's just going to improve your diagnosis. There's an analysis you want to drain it via tooth. Do you have to place a dressing? You want the dressing keep that bacteria to remain in the tooth? No, again, in the past, people used to do open drainage, but I tend not to now. I wouldn't do it because you don't want to. All the aim of what you're root filling and what you're trying to do is actually to remove bacteria from the tooth. So if you leave it on open drainage and all the bacteria in your mouth and saliva get into that area, then you just create yourself more of an issue, and you're leaving like an open communication. So if there's abscess and you can get drainage out through the tooth, but if it's, a lot of it's draining and and it's still actively draining, then you just have to leave it open and let the patient sit for a while until it sort of it is less and less. But I would still always put a dressing inside the tooth and then seal it as well at the end of the appointment. I wouldn't leave them on open drainage because I don't want anything else getting in there. I want to be in control of that field. I've got a rubber dam on, I can clean it. Once I feel it stopped draining, I can flush it out. And if I can get some, calcium hydroxide in there, that's what's going to start to kill off the bacteria that are inside the space, and then your body sort of host response can work outside of that. That's fine. Would you recommend to do an RCT on a tooth where the caries are so deep and tooth structure is damaged until gingiva level? That's more of a restorative sort of issue than an RCT issue. So if the RCT is doable, but I think a tooth is not restorative, not restorable, then there's no point doing the filling. But whether a tooth is restorable, I guess, comes down to either your referring dentist's restorative abilities if you take stuff on referral, or whether they want you to do it, and then it's your own sort of abilities to restore things as well. There's something that might look unrestorable on a on-cone periapical radiograph. When you actually remove the caries, might not be as bad. You might be able to get a sectional band around it, but that's kind of more of a restorative issue. But if the patient was still really keen to do it, I would say, well, I wouldn't necessarily appoint a long appointment to do the root filling. I'd say, well, we need to do a restorative assessment first, clear the caries, restore the mesial or distal part of the tooth first, wherever deep it is, if I can. If I can't restore it, then I'd say to them, look, there's no point doing the next stage. Or if you can restore it, or you can at least see how you then need to restore it, be that crown lengthening, be that, I don't know, if it's a premolar, can you ortho extrude it and get some height that way? So that's more of a kind of restorative consideration, and that, I guess, comes down to your own sort of like your restorative options in your restorative abilities. But yeah, again, if you've got a dentist or dentist in your practice or a dentist that you refer to, a lot of my referrers will just send me a copy of a radiograph saying, do you think this is restorable, or I don't think I can do this, do you think you can do this? And then it's a conversation to have with yourself and your referring dentist at that point. And then again, these are the sort of ones that come down to your discussion and your conversation with the patient as well. If it's someone who's very, very, super demanding and is expecting the world, and they aren't, realistic to the answer this, we don't know until we start, then that might change how you decide to proceed. If it's a hyperinic pulp and we can't do pulpectomy on first visit, is it advisable to put Ledamix and leave it for a few days? And yes, how many days? So hyperemic, you can't, so you don't have time to do a full pulpectomy on the first visit. It's advisable to, you could, so if it's hyperemic and it's bleeding a lot, then you could put Ledamix in there, leave it for a few days before you can get back and actually get it fully numb, I assume you mean. How many days is kind of how long is a piece of string? I mean, it could well be that, even just after one day it's okay. It could be that, it might need a couple of days, but I wouldn't say it needs like many days to do that. I think that's probably more of your kind of own diary and scheduling issue would work on that. If you've got a space in 3 days time, then I'll say I'll come back in 3 days. If you've got a space the next day, then I'll say let's try again tomorrow, because it's probably still done enough to settle it down to allow that LA, and sometimes it's just needs another go. But I've never actually had enough to sort of cases to go, right, okay, I'll try it one day, I'll try it 2 days, try it 3 days. It'd be quite a difficult sort of study to say. What do you use for repairing perforation, MTA or other materials? Yeah, MTA, biodentine. Again, it depends how big and where the perforation is, really. If it's, yeah, it depends how big and where it is. If it's a strip perf in a canal, then maybe some of the biothermic sealers might be enough. If it's a huge, whopping great big perf in the floor of the pulp chamber, something like biodentine is really good because it's quite easy. It's quite move. But if it's big open ABCs or it's perforated from a post canal, then often I'd tend to use MTA, typically further down. But it's whatever you find is easier to handle and manage. Biodentine, there's some issues in some parts is its radio opacity, so you can't always see it as clearly on a radiograph afterwards as well. So depends where you're putting it and what your sort of current guidelines are there. But yeah, both will work. It's just, I guess, what you find best and easier for you. And again, if you don't want to have too much of stock and 2 or 3 different materials, if you just have one and get used to using MTA, then you're going to find that it works for a lot of these things. If you just have it biodentine, you get used to using biodentine, again, you're probably going to find that it works quite well. Biodentine's by Septidon. I don't know if you get that everywhere, but I think that's all the questions.
Yeah, thanks so much, Tom.
No,
yeah,
it's okay.
great webinar. Yeah, so we'll see you again on Wednesday, yeah?
Yeah, I think it's Wednesday, similar sort of time.
Yeah, brilliant. So thanks ever so much.
No trouble. Thanks again.
All right, take care
Cheers,
now.
everybody. Thanks a lot. Have a good evening.
You too, bye-bye.